This conference will now be recorded.
Okay, Tom, I think we're ready.
Good afternoon, everyone, and I hope everyone is safe and healthy. For those of you who don't know me, my name is Tom Carr, and I'm the Executive Director of the Center for Drug Policy and Enforcement, which is housed at the College of Public Affairs at the University of Baltimore. And I'm also the Executive Director of the Washington-Baltimore HIDTA, which is part of the center. As most of you know, HIDTA is a grant program that's funded by the Office of National Drug Control Policy, and the University of Baltimore serves as one of the Washington-Baltimore HIDTA's three fiduciaries, and they've just been a tremendous supporter of our efforts to dismantle and disrupt drug trafficking organizations and to improve the efficiency and effectiveness of our HIDTA initiatives. Some of you may not be aware that the Washington-Baltimore HIDTA and the Northwest HIDTA are the only two of the network of 33 HIDTAs nationwide that fund drug treatment programs. The Washington-Baltimore HIDTA has funded treatment since 1995. At present, we fund 12 treatment initiatives across portions of Maryland, Virginia, D.C., and West Virginia. And our focus is on substance use disorder and those involved with the criminal justice system. We have had tremendous success in our treatment initiatives with reducing the recidivism rate for this population. That is up until COVID-19. So COVID-19, obviously, I don't need to tell you, has impacted all of our lives. But other than the elderly, I can't think of another group that's been more devastated by this insidious contagion than those suffering from substance use disorder. COVID-19 prompted our treatment committee to examine how treatment initiatives are delivering their services, and we formed a COVID-19 task force to examine the issues affecting our region. And the results of that efforts of that committee are what we're going to discuss today. It's now my honor to introduce Dr. Roger Hartley, who is Dean of the College of Public Affairs. Dean Hartley is responsible for helping us secure the University of Baltimore as our fiduciary, and he is a strong advocate for the HIDTA program. Working in partnership with Dean Hartley, we've been able to tap into the many resources University of Baltimore and the College of Public Affairs have to offer. So Roger, let me turn it over to you.
Thank you so much, Tom. And I thank you all for coming today. It's a really terrific turnout. On behalf of the University of Baltimore and on behalf of our president, Kurt Schmoke, and on behalf of the College of Public Affairs, I wanted to welcome everyone to this really incredibly important meeting. Tom, I really want to commend you, Jeff, Laura, and everyone at the Center for Drug Policy and Enforcement and HIDTA for the tremendous work that you have done over the years and for being such incredible partners with us over the past 3+ years since joining our college. I'm really excited to hear about the briefings today. One of the things that is most extraordinary about HIDTA and the work of the center is the opportunities that are there to not only help coordinate law enforcement, but also to work with regional and local governments in order to coordinate the response to drug overdoses, and that being with public health officials, with fire and EMS, with law enforcement, and across localities and across boundaries. Some of the things you may or may not hear about today are some of the incredible initiatives like the Martinsburg Initiative, where HIDTA and the center led an incredible strategic plan across so many different groups in the city of Martinsburg and the county in West Virginia to try to pull together groups that weren't always working together into a place where they could work together to essentially end overdoses. The other incredible initiatives that you're going to hear about and probably know about already, but are the work of ODMap and the ability to track overdoses. And this incredible project has swept the United States, and I'm told is even being used around the world. With that, we've learned that even during this horrible pandemic that we're experiencing right now, we are able to track drug overdoses and learn some really important things about drug overdose in relationship to the pandemic. Has it changed? Are overdoses occurring in different places? And one recent press release determined through these data that there was an increase, or there was a change in the pattern towards suburbs and towards rural areas. The College of Public Affairs, again, welcomes you as well. We do some amazing things. If you don't know much about us, please check us out at the University of Baltimore. But we have a college that's completely dedicated to public service and to changing people's lives. We do that through 3 schools: a School of Public and International Affairs, a School of Criminal Justice, and a School of Health and Human Services. And not only the Center for Drug Policy and Enforcement, but also the Schaefer Center for Public Policy, William Donald Schaefer Center, that's been around for over 3 decades. Putting all that together, to say the least, the work that you all do here and around the country to end drug overdoses fits the mission of our college perfectly and fits each of our academic programs and schools. So again, I want to thank you. I'm looking forward to hearing this report and this workshop, and I'm happy to have us assist in any way. Thank you so much.
Thank you, Roger. Am I on? Okay, great. Okay, so now it's my pleasure to introduce Dr. Laura Picard. I think most of you know her. She's the Deputy Director for Treatment and Prevention for our HIDTA. She's also the Director of Washington Baltimore HIDTA's ADAPT, which is a new division, a division for advancing prevention and treatment. So a few years ago, I spoke at a criminal justice symposium at George Mason University. That's where I met Laura. She spoke just before me, and I knew after hearing her speak that she had what we desperately needed to help us advance our treatment and prevention efforts. So we recruited her at that point. So through Laura's efforts, we've already enhanced our treatment initiatives and created a nationwide effort, like I mentioned, ADAPT, which is designed to provide, among other things, technical assistance to other HIDTAs to improve their prevention efforts across the HIDTA program. If you know her, you know she's a leader. She's one of the few people I know with 2 doctorate degrees, so she's well educated. But the nice thing about it is she has the pleasure of work with, and she gets things done. So Laura, it's all yours.
Thank you, Tom. I appreciate that. That was a sweet introduction. I wanted to just maybe set the context a little bit today for why we're here, because this is somewhat of a new activity for the treatment and prevention arm of Washington Baltimore HIDTA. And it really was an activity that was launched in desperation. It was launched as the result of multiple conversations with various treatment sites that we work with. And we're very happy with the product that's been generated. But we do really see our time together today as really a discussion starter. And we hope that many of you will take away some of not only these recommendations, but this thought process itself, and continue to advance this discussion in your own spheres. Just to tell you a little bit more about treatment and prevention at Washington Baltimore HIDTA, we currently fund within our region, which Tom described, but our region is Maryland, a large portion of Virginia, DC, and the Eastern Panhandle of West Virginia. In that region, we currently fund 11 different treatment sites that work with the criminal justice population and substance use disorders. We also fund 6 different prevention sites, and there really is a wide variety of programming going on between those 2, prevention and treatment. And so we try to have our finger on the pulse of what's going on in our region so we can best figure out how to help. And today's discussion is one way of helping, in our opinion, and we're really trying to provide the best support we can for treatment and prevention across our region. Within our treatment and prevention arm, we have 2 committees, and the treatment committee is comprised of all of our sites, as well as various treatment experts. And similarly, the prevention committee is comprised of all of the prevention sites we fund, along with prevention experts from various fields. Well, the reason we're here today is because around the beginning of May, I started getting calls from members on our treatment committee. And not just one call, but several calls from our treatment sites saying, look, this is happening. We're alarmed by the increase in overdoses in our community, both fatal and non-fatal. And we're not exactly sure what to do about it. But again, out of desperation, we know we need to do something because the rates were alarming in many of our communities. And so after talking with a few of those people, we decided that, you know what, let's put together a task force and let's try to figure this out and get our heads around what's really going on and then come up with a strategy moving forward. So we did. And during the week of May 11th, the task force met 3 different times. And it generated a draft of a report that we'll be covering today. But I wanted you to understand that the goals of us coming together as a task force were really to, again, get our heads around what was going on, but to tease out in more detail the concepts involved in the problem. There were 2 public health crises clashing, coming together, and we wanted to make sense of what was going on. And so beyond just teasing out those concepts, we also wanted to synthesize some of that messaging and those key messages within the concepts to better organize our thoughts around this. And then we also thought, after seeing, multiple sets of recommendations coming out from various organizations, like the American Medical Association and other public health organizations, there were a wide variety of groups. Even Maryland Opioid Operational Command Center has recently produced something. But really moving into our task force with this idea that the product that is generated really would be a complementary product because it's representative of what we're seeing in our region. And we wanted to provide it as a resource as well as a strategy moving forward. So just to give you some sense, a sampling of sorts of the data, before I talk about the data you're seeing on your screen right now, I did want to go back to something I believe Dean Hartley mentioned. ODMap is one of the tools that Washington Baltimore HIDTA has developed, and like you said, it is being used around the nation, if not the world. And you can find many of their reports. They have been following this as well. Many of their reports are housed on ODMap.org. So please visit that website for more of an aggregate representation, and you'll find various themes that are emerging from the increase in overdoses. So I definitely wanted to send you there for more information around that. But for the purposes of this report, we went straight to the counties and to the organizations and asked for the exact data that they had been collecting over a 10-week time frame in 2020 that would represent much of the COVID era that we've been experiencing. And so between March 1st and May 12th of 2020, we asked them for the total number of overdoses, including fatal overdoses. And we also asked them for the data from 2019 during that same 10-week time period so that we could essentially look at the percent change in overdoses. And what you see here on your screen really is a variety of responses to COVID-19 and its impact. And I think it's really important to note here that it has been variable across our region, but the numbers in red really do showcase how alarming and how much of an impact it has been in some of our communities that we represent. And just to draw your attention to Berkeley County, down at the bottom in West Virginia, experiencing a 245% change in total overdoses, including 120% change in fatal. And even looking at Virginia, we've got our Northern Shenandoah Valley region represented here with significant increases in this variable. So we wanted to do something, and we went into this knowing that it wasn't going to be a simple solution or a simple strategy, but it would be layered and multidimensional. Therefore, we brought together a task force that really would help us understand all of the lenses and perspectives that we might need for our region. And we wanted it well represented. So what you see here is a list of all of the task force members. Lauren Cummings out of Northern Shenandoah Valley and Tim Saya out of Berkeley County, West Virginia. I asked them to be the co-chairs and kind of lead this effort and the discussion around it. And thankfully they obliged. And the other members of this task force really represent our entire region, various treatment experts, as well as health department representation here, as you'll see. So beyond the draft of the report that we generated, we then decided we needed to send this out to an external review committee just to make sure that what was being presented was resonating with others in our region and also with national experts. And so we did. We sent it out to various prevention, treatment, and recovery experts, both at the county, state, and national levels, and really got their input on the report. And I have to tell you, that particular action was priceless because the task force generated an extremely strong report with an infrastructure that lended itself to being fleshed out in many ways by this external review committee. So what you will see and have access to at the end of this webinar is a report that really represents a balanced approach to this particular situation and the recommendations, and also hopefully helps to characterize the problem itself in greater detail so that we have a direction moving forward. So the purpose of this webinar is to review those findings. It's also to share local, state, and national perspectives on the report. We've invited 4 dynamic panelists to talk about this report today. And then we do not see this report as the end-all be-all in any way. It really is, again, a starting point, but hopefully a firm starting point that will continue to advance the discussion moving forward. And we're hoping that it will provoke other thoughts in your mind and that it will empower you to carry this forward in ways that make sense for you in your own areas. So with that, I'm going to introduce our co-chairs who will be talking us through the content. Lauren Cummings is the Executive Director of the Northern Shenandoah Valley Substance Abuse Coalition in Winchester, Virginia. She also serves as the Virginia Governor's Advisory Commission on Opioids and Addiction, serves on that commission. Under Lauren's leadership, and I've had the great pleasure of working with her for several years now on a variety of different things, but the Northwest Regional Adult Drug Treatment Court was launched in 2016 under her leadership to divert high-risk individuals charged with nonviolent drug offenses out of incarceration and into treatment. Lauren has also been heavily involved in regional community outreach and led efforts to launch roadtorecovery.info. That website is roadtorecovery.info. It's a centralized online resource for individuals and loved ones impacted by the disease of addiction. So we're very happy to have her with us today. Tim Saya is the other co-chair. He's been serving as the Director of Berkeley County Community Corrections in Martinsburg, West Virginia since 2016. He oversees the operation of the Berkeley County Day Report Center, Berkeley County Home Confinement Program, and the Berkeley County Recovery Resource Center. He's a certified addictions counselor and has been working in the field for over 15 years. He also has many years of experience running a therapeutic community in Dauphin County Prison in Harrisburg, Pennsylvania for violent offenders. So thank you, Tim, as well for joining us. And I'm going to hand it over to you to discuss some of our themes.
Thank you, Dr. Picard. I appreciate the introduction. One other thing about me that I don't mind sharing is that I grew up here in Martinsburg, and I became a young heroin addict when I was about 15 years old. And I lived in the prison of addiction for about 7 years. I was in and out of treatment program after treatment program, and I was hopeless. I finally found myself at the age of 24 in a long-term faith-based program called Teen Challenge, and my heart and my life were changed forever. That experience that I had with addiction and the freedom that I found impacted me so greatly that I decided I wanted to go to school and work in this field, helping those who are suffering as I once did, and I've done just that. Most of my professional experience, as you stated, came from my time at Dauphin County Prison there, which is what got me into the field of corrections. And as we all know, so many people who end up in legal trouble are there as a direct result of substance use disorder. So I wanted to share that with you all just so that you have a little bit better of an idea of the lenses that I see through. Over the last several months, we have all watched and experienced the unfolding of a national and even worldwide reaction to the new COVID-19 pandemic. And I think we would all agree that it has been quite a learning experience, to say the least. The most common reaction that I think most of us have witnessed was shut it down. Everyone go home and stay home. These shutdowns included small businesses, restaurants, hair salons, movie theaters, factories, so many types of jobs that people who are in early recovery are able to obtain. These shutdowns included, in addition to those places that I mentioned, community-based recovery meetings, Alcoholics Anonymous, Narcotics Anonymous, Cocaine Anonymous, I could go on. Outpatient substance abuse treatment groups, individual therapy, community-oriented recovery programs were closed. Inpatient detox programs and treatment centers stopped accepting new patients. Even community corrections programs like the ones that we run here in Berkeley County were closed. Parole and probation offices were closed. Officers and staff were instructed to stay home, not to interact with offenders under their supervision. Well, guess what happened? Drug use began to spike, overdoses began to spike, and unfortunately overdose deaths began to spike. At least that's what happened here in Berkeley County. I know some other areas as well. After about 2 months of these COVID-19 restrictions being put into place here in Berkeley County, there were 6 deaths that were said to be associated with COVID-19. And I know that's a small number compared to larger cities, but that was our reality here. During that same period of time, there were 16 deaths due to overdose. And that simple statistic troubled me significantly because that was a significant spike in deaths here in Berkeley County from overdose. But what was I to do? I decided to make some phone calls. One of them was to Dr. Picard. Coincidentally, my phone call to her and the purpose of my phone call mirrored a phone call made by Lauren on the same day. And I think those 2 phone calls are part of what led us to this point. Just a few days later, we had our first task force meeting that was spearheaded by Dr. Picard. And I think we can really primarily thank her for the fact that this webinar is happening now. Before I get into describing the problem, though, I just want to quickly just kind of remind everyone that those people who are early in recovery are trying really hard to climb out of a very dark and lonely hole. Most who have arrived at their bottom have done so in severe isolation and loneliness. Their familial relationships have been severed. Healthy social relationships that they once had have been non-existent for some time. And that very basic human need for relationship and community has been lost. Rebuilding those relationships with other human beings early in recovery is imperative. COVID-19 restrictions eliminated that aspect of recovery for many. Jobs were lost. Community recovery groups were shut down, as I previously mentioned. All these community-based meetings that many in early in recovery so rely on day to day were closed. people that were ready for and needed to get into and were ready for inpatient detox and treatment stays. Those programs were not accepting new patients. Harm reduction programs were closed. People were told not to visit with their elderly parents and grandparents. I could go on. But the rebuilding of those relationships that those people were in the process of rebuilding early in recovery, that process was halted. And these factors were huge contributors to increased vulnerability of an already very vulnerable population. The average person fighting to stay sober on a daily basis very suddenly lost their job and had no possibility for community-oriented socialization and recovery options. So during our first couple of task force discussions, there were 4 primary themes that emerged that we wanted to highlight. The first of those 4 themes is what I mentioned a moment ago, and that's vulnerability. The recovering addict, the recovering person suffering from substance use disorder, especially those early in recovery, are extremely vulnerable. It doesn't take much to trigger a relapse. For many years, the only way that those people were able to find any type of peace, if you will, comfort, was by using substances. You know, their list of triggers is fairly long early on. Some of the most common triggers for those early in recovery are stress, financial hardship, social isolation, depression. COVID-19 restrictions resulted in all of these triggers for many people. The second theme that emerged is connectivity. As most of you have probably heard, the opposite of addiction is community and connectivity with other people. Addiction is generally practiced in isolation. Addiction is healed through meaningful human interaction, relationship, community. Most of you are probably familiar with Maslow's hierarchy of needs. There at the bottom of that pyramid are the physiological needs, food and shelter. Then there's safety. Then there's love and belonging. Then there's esteem, and then self-actualization. Well, right there at the center of that pyramid is love and belonging. Love and belonging, in my view, cannot be fully achieved through video conference, which is what many programs ended up resorting to after these closures took place. That's what we resorted to. It was our only option. One of our peer recovery coaches during one of our conversations made this statement, and I agree with it. The recovering addict needs a daily dose of a recovery meeting, and more importantly, the meeting before and the meeting after the meeting. The addict in recovery needs to be with people who are like-minded, who understand them, and then who also hold them accountable, which leads us to our next area of focus, which is accountability. The recovering addict needs to know that other people are watching. Their eyes, their appearance, their body language can all be telltale signs of relapse. Knowing that they will be in the presence of others is a helpful piece of motivation for them to stay clean early on. The importance of the accountability piece in community corrections programs, parole, probation, is absolutely vital. There are many who, if not for the accountability of face-to-face drug screening and group therapy and conversation with people in positions of authority over them and even their peers, would relapse. The accountability piece alone is what keeps many people in early recovery clean today. So the fourth and final theme that emerged during our task force discussion was access to care. And I know I've probably mentioned these already, but to reiterate, because it's so important, those suffering from substance use disorder need constant access to a variety of treatment options. And COVID-19 restrictions resulted in the closure of our community-based recovery meetings, our NA meetings, our AA meetings, our CA meetings, our CR meetings, our RU meetings. There are many that go on. You all know this. Outpatient substance abuse treatment programs closed. Inpatient detox and treatment programs not accepting new patients. For many, just having a job that they're able to fill their time with keeps them clean and sober. So you take that away, and now idle time is the devil's playground. All these are contributing factors to increase in overdose death, overdose death, drug use. All these just contribute to that problem. So we have to figure out how to balance managing the COVID-19 pandemic while also not forgetting that we have this drug epidemic that has been going on for some time and continues to go on. We can't neglect that population. So that's a quick snapshot of the 4 themes that emerged through our task force meetings. And I will now turn it over to Lauren Cummings to discuss recommendations.
Well, thank you so much, Tim. And before I outline the task force recommendations, I wanted to share that on June 10th, in the midst of this pandemic, Huey McGee, who is the director of Rivendell Recovery Center in the Northern Shenandoah Valley, and who also served on this task force, celebrated 50 years in recovery. As we consider, I see Tim is clapping, as we consider strategies to address the challenges faced by individuals with a substance use disorder during this pandemic, we are not just thinking about those who are in active addiction. We are also considering those who have spent years, and some, like in Huey's case, even decades in recovery, but they are also realizing the trials of this time. The task force outlined, as Tim mentioned, recommendations to address the identified challenges of vulnerability, connectivity, accountability, and access to care. The first recommendation is for federal agencies specializing in substance use disorder prevention, treatment, and recovery to collaborate with public health agencies to generate and initiate the following products. The first are public service announcements to promote prevention strategies and awareness of resources. Many individuals during this pandemic are staying home and are engaging with others on social media platforms as well as watching television. And we would utilize the media to offer messaging for self-care and healthy coping strategies like mindfulness. Our goal would be to direct viewers to state or community level resources. We would recommend sharing messages to reduce the stigma of substance use disorders, and many of these messages would shine a light on recovery and offer hope to those in active addiction. Another recommendation is to provide specialty guidance for states, which increases their awareness of vulnerabilities to those with a substance use disorder. The guidance would include addressing the importance of adaptations to state-level restrictions for substance use treatment and recovery services. Counties with few or no positive COVID-19 cases could possibly continue to operate treatment and recovery services as usual, while obviously maintaining and monitoring the increases in the cases and adjusting as needed. There would be the development of an informational feedback loop among federal agencies, states, and counties to receive feedback on the effectiveness of these efforts. Funding would be secured for technology resources to ensure that everyone has access to virtual services. And there would be relaxation of telehealth regulatory barriers to ensure that access to these services remains an option for individuals who benefit from it. Moving to the second recommendation, in our community, we are very fortunate to have the coalition, which really serves as a coordinating and advisory body for operations relating to substance use treatment and recovery. And we recommend that states task a specific state agency with identifying organizations like the coalition at the local level who can serve this purpose during crises like COVID-19. These organizations would be responsible for ensuring state-level guidance on safety protocols, as well as substance use disorder services and resources are disseminated. It would be responsible for supporting wellness and healthy coping strategy dissemination through prevention professionals in each community, advising treatment and recovery organizations on implementation of the guidance and proper documentation, supporting participant engagement to decrease social isolation through creative use of social media messaging and virtual services. They would work with the community partners to develop alternative protocols for administration of randomized drug testing programs for programs like the drug treatment court. In our community, we were very fortunate to already have a collaboration with Valley Health System in place. Typically, our drug screens are done through probation and parole offices, but unfortunately, they were not drug screening during the COVID-19 situation. And so we were able to rely on an already existing relationship with Valley Health System, where our clients were able to go to the different health urgent cares in our community to receive drug screening. So that in our community was not interrupted, but we spoke to a number of other communities where they were no longer able to drug screen their drug court clients during this time. And finally, they would be responsible for accelerating access to safe and socially distanced harm reduction services in an effort to save lives. The third recommendation is for all states to receive federal funding to develop or enhance a 24-hour hotline that can immediately connect people to substance use treatment resources. In neighboring West Virginia, there is a Help for WV hotline. That is a tremendous resource for individuals who have a substance use disorder, and it assists them with being referred to treatment services. The hotline would have a real-time list of available beds, would assist them in applying for Medicaid, facilitate the transportation to the treatment location, and connect with other states to locate a bed if it was necessary. The hotline would offer translation and deaf and hard of hearing services to also facilitate communication. Now to the fourth and final recommendation. Another challenge that has been faced by many communities, including ours in the Northern Shenandoah Valley, is reentry programming. Many individuals were released early from jail due to fears of a COVID-19 outbreak in the detention centers, and they were released with little to no resources to support recovery. The fourth recommendation is to equip these individuals with Narcan, arrange for a warm handoff to treatment, including medication-assisted treatment, and also assist them with applying for Medicaid benefits. We had cases in our area of individuals who overdosed within hours or even days of release. Some unfortunately even died. And they would, in some cases, be rearrested following an overdose and would be released again the next day with, again, few resources. It is our hope to minimize this disruption of crises like the COVID-19 pandemic on our most vulnerable populations. Implementing these recommendations will not only help individuals with a substance use disorder weather the storm, they will also assist individuals who face the addiction crisis for years to come, so that more people in recovery can celebrate tremendous milestones like our friend Huey. Laura?
Thank you, Lauren and Tim. What a beautiful job you did describing a multiple-page report in just a few minutes. And thank you for really teasing out a lot of the issues, Tim, giving specific examples, and Lauren for really consolidating some of our thoughts in these recommendations and also providing details from your community. What we've done is we've asked for wonderful panelists. I mean, if you read their entire bios, you would be amazed like I was. It was really hard picking and choosing what I would be using to introduce them today. But we decided to get some feedback, both on the content of the report, but also to ask these experts to share kind of other thoughts they might have and to give us some perspective as an audience on how we can best utilize this report moving forward, how we can advocate for some of this change and some of this infrastructure development so that we can be better prepared when the next COVID-19 hits or another wave of it does, and set these people with substance use disorders as well as prevent the onset of substance use moving forward. So I'm going to briefly introduce our 4 panelists, and then we'll hand it over to them. Tamara Starnes has been the Chief Clinical Officer at Blue Ridge Behavioral Healthcare in Roanoke, Virginia since 2015. Prior to this, she was the Director of the Forensic Services Division for the Charleston Dorchester Mental Health Center in South Carolina. She has 20 years of behavioral health experience and is licensed as a professional counselor in multiple states. She's been recognized by NAMI as a NAMI Mental Health Professional of the Year and has extensive experience in mobile crisis work, justice and mental health collaborations, critical incident stress management, and evidence-based trauma treatment. Our next panelist is Laura Yeager, who is a systems change agent and has led a variety of initiatives in primary and behavioral healthcare integration and diversion of people with behavioral health issues out of the criminal justice system and into treatment. She's developed 2 nationally recognized evidence-based substance use prevention programs. She is presently the Director of Correctional Health and Human Services with the Fairfax County Sheriff's Office, where she is addressing complex COVID-19 issues and standing up jail-based medication-assisted treatment and reentry recovery services to reduce recidivism and overdose. Our next panelist is Dr. Joshua Sharfstein. He is Director of the Bloomberg American Health Initiative, Vice Dean for Public Health Practice and Community Engagement, and Professor of Practice in Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. Previously, Dr. Sharfstein served as Secretary of the Maryland Department of Health and Mental Hygiene, as Principal Deputy Commissioner of the U.S. Food and Drug Administration, and as Commissioner of the Health for Baltimore City. He's an elected member of the National Academy of Medicine and the National Academy of Public Administration. Dr. Sharfstein teaches a class called Crisis and Response in Public Health Policy and Practice and is the author of the Public Health Crisis Survival Guide, Leadership and Management in Trying Times, published in 2018. He is also the co-author of the book, The Opioid Epidemic, What Everyone Needs to Know, published in 2019. And our final panelist is Gail Maddox-Taylor. Gail Taylor is the Director of the Office of Behavioral Health Wellness for the Virginia Department of Behavioral Health and Developmental Services, where she leads the development and implementation of comprehensive substance use disorder prevention systems at the state and community levels and oversees a variety of initiatives, including the state's SAMHSA Substance Abuse Prevention Block Grant, Suicide Prevention and Mental Health First Aid statewide initiatives, Strategic Prevention Framework initiatives, and Behavioral Health Disparities initiatives, including refugee and adverse childhood events programs. Ms. Taylor is the National Association of Substance Abuse Directors representative for Virginia and currently serves as the first Vice President for External Affairs for that organization. So welcome to all of our panelists. What I've done is I've asked them to spend 10 minutes each sharing with us their perspectives on the content, how we should think about it and utilize it moving forward, and any other thoughts they might have on the subject. So Tamara, I'm going to turn it over to you.
Thank you. As was mentioned, I am the Chief Clinical Officer at a community services board. So for those that don't know what a community service board is, we're basically a publicly funded system that helps treat folks that have substance use disorders, mental health disorders, and people with developmental disabilities. So we're really seen as the safety net agency in our community. And the report definitely hits home with us because of the vulnerable population we serve. So we've got a wide geographical area we serve that's a real mix of rural areas, urban areas. We have some wealthy pots, and we've got some high poverty spaces. But the vast majority of our service area and the people that choose to come see us do have multiple vulnerabilities or more than one disorder or co-occurring disorder. So we typically see ourselves as serving a real purpose in the community. As was mentioned before with some of the data and ODMaps looking at overdoses, we have seen a dramatic increase in our area. And when COVID-19 hit, we had to switch really quickly to the telehealth model. So we also appreciate the report just sort of reinforcing and making recommendations about some of the strategies that we were able to put in place that helps us feel like we've been on the right track, and then also gives us some thoughts and guides for strategies to even better improve our response. And we are one of the areas that's lucky enough to continue services throughout the entire pandemic. So we have a same-day access model, which means you can come into our center and get services without an appointment, Monday through Friday, 8:30 to 3. So we've been able to keep that open. What we did see with the pandemic is when some of the stay-at-home or safer-at-home things came down, people coming in to see us was less. So we had a really quick downturn of probably about half the number of people that normally come and seek help were showing up for that. On top of that, we also saw about a 25% decrease in our emergency services calls. So whereas some might think initially that means, hey, people are doing okay, I think what we actually believe when also factoring in some of that overdose data is that it's really showing that there are people that need help that weren't getting it. So for whatever reason, whether that was the fear of coming into a clinic where there were other people physically here and the risk of COVID-19, or just trying to follow governor's orders, whatever reason, people weren't coming in. We moved a bit further and worked to make our entire process total telehealth, from intake to treatment for those that chose it. So we always want to keep a choice out there for clients that may be able to come in and seek treatment and need that. But we also found that we did have more people actually start seeking help when we were able to offer a 100% telehealth option versus walk in the first time and then we'll get you set up and you can start telehealth. So, I think there's all kinds of, thoughts about telehealth. Is it helpful? Is it not helpful? I think we've seen it on both sides. We've seen numbers go down, not as many people seeking help. We've also hit this piece of kind of like a digital divide, meaning we have a subset of people that don't have a telephone or don't have a computer or don't have access to internet or enough data minutes on their plans to even engage in telehealth if they want that option. So, for us, having a little bit of both has been good. Interesting thing we found was most of the people that were seeking services have stayed in services. So our retention rate in services has been better. I think our theory on that is, and again, it's just a theory, is that idea of people need each other. We've just had folks going through so much like chronic and prolonged stress, particularly if they don't have a job, are dealing with substance use, as was mentioned early in recovery. So I think some of the telehealth at least has been able to keep folks a little bit more connected than maybe they were before entering treatment, just a little bit of support. So that's been an interesting number for us, just to see that those that have sought treatment have seemed to stay a little bit more. Another really important thing for us has been, and I think that's reflected in the report as well, is trying to get the information out there as far as public service announcement, prevention efforts, and really letting people know we're here. So I think folks originally thought the state shut down, everything's closed, and didn't always have an awareness of which treatment centers might be open, which treatment centers might not. Is our detox still open? Is it not open? And so getting that word out, I think, has been helpful, particularly through news media, reporters, any other agency documentation we can send, putting it up on websites. We're here, we're open, has been good for us. We've also really appreciated the guidance we've gotten from DBHDS, our oversight body, and Virginia Department of Health, and also having a really good connection with our local health department. So those things have been instrumental relationships for us and information pathways to help us feel confident in what we're doing and how we're delivering services and how we're able to deliver services. So probably, one of the biggest things for us that we really, really like about the report and are on board with is the idea of continuing with some of the relaxing of regulations around the delivery of telehealth. So for example, prior to the pandemic, delivery of group counseling services was not a reimbursable, for example, Medicaid service. It couldn't be done by video. And for some folks that may have transportation barriers or childcare barriers, I think it'd be a small percentage of people, but for that percentage of folks, I think we really hope that some of those things can continue more long term so that we can keep people engaged. We found our no-show rates went down for some of our psychiatry appointments, for example. So I do think that shows that there is a subset of people that sometimes telehealth can help overcome some barriers. But then also on the other side, that in-person is important, and we want to offer that as much choice as possible too. Working with our community has been good for us, so that really trying to share the reports coming down the road with other people we work with, like we have a Healthy Roanoke Valley initiative that's out there, or a collective response to the opioid epidemic group that works together. If everybody kind of has the report and is really taking in some of the recommendations, it may provide more common ground for us as well, how to really address the issues more systemically in the community. So for us, the report was really good. I think we appreciated sort of the viewpoints of multiple sides of things and what might be helpful. And again, we're just really hoping to be able to move forward long term with as much choice for people as we can as far as what works for them for delivery of service. And that back to you.
Thank you, Tamara. That was wonderful. Debbie Bonnywell is your CEO there for your CSB, and she was one of the external review committee members, and she recommended you be a panelist because you have this breadth of knowledge related to that clinical piece, and we really appreciate your insights into this. And I also think it's very important to hear what you're saying, because as you saw in the data, it's just been so variable, and to hear from the treatment side of things within your community that telehealth really was a motivation and actually more engaging for that subset of those with substance use disorders. I think that's just a really critical point, because there are those that just don't respond as meaningfully to that modality versus those that can, and just demonstrates the variability in how the approach needs to be multifaceted. So thank you for that. Laura Yeager, we'll hand it over to you, Fairfax County.
Thank you so much. Before I start talking about a little bit about what we're doing and about COVID, I want to talk a little bit about this report. I'm someone who is always looking for a resource to quote or to find expertise to make a case for what I'm trying to do. It's difficult to be a prophet in your own land, but it's always great when you can find a report that's going to substantiate what you're trying to move forward. So I really appreciate this report. It's helpful from a boots on the ground perspective and supporting your implementation of different services and programs. I think it's also something that is going to be able to influence policy, whether it's writing to the governor of your state, writing to legislators who might be able to shift policy to make very simple changes that are going to affect outcomes. I see that as an important piece. I think this document is also all about collaboration, and it's looking at us to come together with different groups to move forward. So If for those of you on the call and just in thinking about what do you do with this report, because a lot of work went into it. You don't want it just to be a yay, we did a webinar and put it on a shelf, but how you can use this in your day-to-day lives is really important. And again, if I have a reference point to demonstrate why, in my case, we have to do rapid reentry, I can pull this out. And so get just another tool for the toolkit in advocacy moving forward. A little bit about what I'm doing. COVID, I work in a jail. COVID has certainly been very impactful to the work that we're doing. So we're trying to stand up medication-assisted treatment. At the same time, we're addressing COVID in the jail. And I don't think any of you out there haven't seen news about prison systems and local jails having deep impacts with COVID. We're really lucky right now in Fairfax County because our population has dropped dramatically. We have had about 8 cases of COVID within our inmate population that we've been able to successfully contain. We're able to quarantine people very effectively, move people effectively, but back to the HIDTA kind of collaboration model, this would not be happening if we weren't in an unprecedented fashion sitting down with the primary care providers, our healthcare providers in the jail, our sworn staff in the jail who are responsible for where we put people and how we deal with them, and our behavioral health staff. And for my locality, that's a CSB who are co-located with us at the jail. So all of those things just really point to the collaboration for having an effective COVID response. It has truly forced us to come together in a great way. I'm someone who has a whole person approach to treatment, both in primary care and behavioral health care. And if we're only focused on someone's head or we're only focusing on somebody's body, we're missing a lot. So I hate to say this opportunistic reason that, to have COVID impacting us in this way, we're all coming together to work on addressing it, and we've been extremely successful. So a little bit more about our efforts with HIDTA and with our medication-assisted treatment approach and our reentry. We're really looking at particularly opioid use disorder, but any substance use disorders as a chronic care issue. It's a chronic disease. It is not some specialized little behavioral health thing that we stick over there in a corner and we refer people to. We're really embracing this idea that we're all in this together and we're all co-treating people, and that helping people withdraw when they're arrested and they're in jail is a medical issue. We have medical care 24/7 at the jail. We don't have behavioral health care available 24/7, but it requires us to all be together in treating someone. So I hope that makes sense. It's a huge cultural shift for corrections. It's a huge partnership shift for a CSB and medical services to be working together. And it can be really challenging, especially during this time when you can all go, yeah, we can't do anything because we have this COVID that is consuming all of our time. About the report and a little bit about what we're doing, and please nod at me if I'm kind of bumping against my time, because I can talk for hours, and I know you don't want me to do that. When the recommendations in the report about rapid release planning, we look at release planning to start at booking. So if someone is arrested in the jail, we need to start thinking about their departure from the jail. Jails don't tend to be long-term facilities where people stay. In our jail, people stay for about approximately 30 days, but some people can be there for up to 2 years. It's an opportunity to really set a standard for getting people a foundation in recovery. So the recommendations in the report, including equipping people with substance use disorders with Narcan or naloxone upon discharge. We actually do revive training in Virginia. We do revive training, which is a training how to use naloxone. We do it with inmates in the jail, and you can't just go, hey, here's your medication. You can't carry that around at a jail. So we actually have set up a process where we put it in their property that is released to them upon their release. So they have been trained before they leave, and they have naloxone in their possessions. We're also looking at, as we introduce MAT, medication-assisted treatment, bridge dosing folks and partnering with our CSB partners for outpatient treatment with an appointment before they ever leave. Like we want to have a case management component. So, because we know the minute someone leaves jail, it's really easy to keep someone not using when they're in the jail, because it's kind of hard to do that. But when they leave, we know they're highly likely to overdose and die and or recidivate because of their addiction issues. So we're really involved in case management and assuring a strong connection to hopefully the same day they're released to the outpatient clinic. We have a really great grant from HIDTA. I feel like, you know, a schmoozer here, but one of the things it's doing is in the kind of the old criminal justice way of looking at things is when you've done your time, you're done. We know that if we let someone out and they have addiction issues, that there are huge risks for bad outcomes. So with this small grant and where we're really focused on reentry, not just about naloxone, but we have a small amount of money to help people with recovery housing, if that's going to support them to stay in recovery. We have a peer position, someone with lived experience who's helping engage people. Not everybody wants to be on a medication for addiction, so we're providing a tremendous amount of education and then linking them to those community supports. If someone is leaving jail and they have an appointment down the road at the outpatient clinic, we're offering transportation. All of these things are outside of the normal realm of what a sheriff's office does or handling a jail, but it's all about the collaboration. It's all about building those connections to give people the best opportunity when they walk out the door, that they have a safety net there. It's a real different approach, I think, to what criminal justice has done in the past, but I do think it's a wave of the future, and I think your report reflects that. Just one more thing in your recommendations I forgot to mention, the Medicaid application for Medicaid benefits at release. In Virginia, we can actually do an application 45 days prior to release, and our sheriff has created a reentry counselor position. I believe she gave up a sworn position to do that, and we're trying to get people enrolled in Medicaid and also with a medical appointment with one of the federally qualified health centers, so they have an appointment walking out the door. Because all of those things are going to be elements that help prevent relapse, help prevent overdose deaths, and help prevent recidivism. I could talk way longer, but I think I'll let someone else have a few words.
Thank you, Laura. Just to kind of emphasize one of the points you made, in the spirit of preparedness and being a little more prepared, you know, lessons learned, right? So that we can develop that infrastructure. Those rapid reentry protocols, while maintaining this ability to fully assess in critical ways what's needed, you know, in connection with the variety of services that will be needed upon rapid release from jail. On the flip side of that, Tamara, I know you have to leave very shortly here, Tamara, so thank you for joining us today. I don't want to hold you up, but one of the comments that came in from Debbie on your end when she reviewed the report was that it's not only on the end of the jails, right, in the prisons, that you all had several of the rapid releases actually sitting in your waiting room ready for treatment and services, and it would have been nice to have a heads up around that as well. So developing this infrastructure so that when the time is needed, right, to implement these, then they can be rapidly implemented while not losing the quality of the care that is needed, but also so that others can be prepared to actually deliver those services and do the intakes that are needed. Okay, I'm now going to pass it over to Dr. Joshua Scharfstein, and I just want to thank him personally here publicly he was the first one who responded with comments on the report, and he's just been very engaged with us throughout this entire process, and we really value his opinion like we do all of our panelists and all of the task force members. But I just want to personally thank you for that, because I felt like you were very connected in this process, and it really means a lot to us. We appreciate it. So I'm going to hand it over to you to offer some of your comments.
Great. Thanks, Laura. Thanks for including me, and great work. such an interesting conversation. So, I think what we're dealing with is, as has been said, an epidemic in the pandemic, and it's complicated. We haven't talked this much about it, but there are a lot of people who suffer from addiction who are at very high risk for serious illness and death from COVID. So we're trying to accomplish both things. We want to keep people out of harm's way from their addiction and also keep them out of harm's way for COVID. And we know that people have other chronic illnesses. They may be older, and they may live with people who are older, so that if they themselves are not higher risk than others, they could have hypertension, diabetes. And so there's a major challenge here of being able to do two things at once. And I totally understand that it's very hard to do that. And some people who know me know my wife is an addiction medicine doctor, and she was just terrified for her patients, both because of the risk of overdose and the risk of COVID. And we, in fact, did have some COVID outbreaks in Baltimore in some recovery homes, which are very serious. So, how do you do that? How can you do that? And what I like about the report is it calls out a couple really good ways to do that. One of them is the regulatory flexibility that was necessary to be able to keep people in treatment even while reducing the number of people in facilities. And I totally believe that it was a shock to the system. It was a shock to the system for medications. I'm sure it was a shock to system for counseling. And so it was a very bumpy transition and very difficult for people. But as that then has gone on, there have been new models that have been worked out, new ways to do counseling, new ways to deliver medications. And I think the idea that where those have worked for people, it's really important to keep that flexibility. I'm very concerned that the federal government will just push a button and say, okay, COVID seems to be less, flexibility over, boom. And then we'll just have lost the opportunity to understand what was of benefit to people. The rules that we have are not based in science. The rules on methadone, only the United States has. The rule at that level. The rules on buprenorphine are, over the top compared to most other countries. They come out of a history that has always treated treatment more aggressively than opioids for pain. They don't make sense from a public health perspective, in my opinion. We have overregulated treatment. And so now this opportunity to rethink regulation in the pandemic gives us an opportunity to figure out what is the right thing. And I'm not, saying that exactly this should be done, but I do think pushing the button and just going back to the way things were will leave a lot of opportunities to help people off the table. And I like the idea that it should be based on experience and information and data, and not like a reflexive, let's just go back to the way things were. I particularly like the idea of using the regulatory flexibility to help even more people. So there are interesting opportunities to address the epidemic and the pandemic. One of them is the absence of an in-person requirement for buprenorphine treatment, which, as you may know, reduces the risk of overdose by 50% or more. And so it associated with extreme progress in terms of reducing fatal overdose. And yet people have had such hard time accessing the treatment. States that are able to use this flexibility may be able to team clinicians with peers and outreach workers to find people and get people treatment right there, right when they're ready. One of the things that has always held back treatment is that people haven't been able to get started quickly enough before they start to go into withdrawal and wind up using again. And when people can get treatment before they go into their next withdrawal, the rates of success are double. That's why ER programs are so successful, because people are there, they're about to go into withdrawal, you give them buprenorphine, you cut off the withdrawal. That doubles the rate of success in a randomized study from 35 to 78%, getting people successfully into treatment a month later. And so if you can do that, without people even having to go to the emergency department, not having to worry about getting to a treatment program that might be closed or might not have space, but set up 24-hour access to that, the chance of getting people when they're in the mind to do it and cutting off the withdrawal that keeps them using again and again and again, you have just a huge potential opportunity with the regulatory flexibility. So I think a hotline can really play into the opportunity that's here. I would say that I appreciate the recommendation on better transitions out of detention. I think there is a particularly, strong rationale for doing that, and there's a great rationale also for starting people into treatment while they're still incarcerated. The evidence is very strong from the United States and elsewhere that if you do that, you can dramatically reduce the rate of overdose. But I think that the moment here calls for a couple things that I would say maybe go a little bit beyond what's formally in the report. And those relate to two areas. One relates to harm reduction. I didn't see a huge discussion of harm reduction in the report, but when people were let out of prison so that they didn't die of COVID, and they, some of them, were, it was haphazard being able to be linked to treatment. You want to link everyone to treatment if you can. Some people aren't going to go to treatment. What are they going to do? How do you help keep them alive and engaged so that they can put the pieces of their life back together? And harm reduction has a very strong evidence base for that, not just naloxone distribution, which is in the report, but also syringe service programs and other types of education and engagement. And figuring out how to do that in a pandemic and reducing the barriers for that is going to be very important. People feel, the anxiety and stress of everything going around, has led some people to relapse or to use more, and engagement is one of the best tools that can move people along towards the kind of treatment that we all want them to have. And so really taking this opportunity to think about how that can be done in creative and safe ways is very important. And then finally, I would say that we have to pause for a minute and think about the overall criminalization of drug use and how that has contributed to the cycles of people going in and out of jail and the difficulty that people have sometimes in getting treatment. We have, unfortunately, far more than any other country, put people in jail for what I think we all recognize is a condition, an illness of addiction. And this is a moment to rethink that, I think, both because of the evidence that it has not really worked, because of the moment we see, because of the examples and concern about racism in the police. But more generally, I think it is a moment to pause and really ask ourselves, do we need to be using the criminal justice system for some of these functions anymore? When people are in trouble, when they are drunk in public, when they are, intoxicated, do we need to be calling the police? Is there another answer to that? That's a tough question, but I think it's a question that needs to be asked now. And I think that the HIDTA, by bringing people together, is in a great position to ask tough questions like that, and to say, maybe it's time for us to think of very different models to respond to overdoses, to respond to reports of intoxication. Let's empower the treatment system. Let's reduce the need for corrections to have to worry about making connections, because there are fewer people who need to go to corrections in the first place. We have a system that is so heavily based in the police and jails because of our history, not because of evidence that it works. And maybe this is a moment to rethink that too. So I know I've been a little provocative, but I will happy to further discuss, and back to you, Laura.
Thank you. I think I speak for all of us when I say we appreciate you being provocative, because the purpose of really holding this webinar was to get people thinking about these types of things, including new ways of thinking about them. So thank you for that. Okay, and now I'm going to pass it over to Gail Taylor, who I've worked with on multiple of prevention initiatives. But Gail, over to you.
Okay, thank you, Laura. I really appreciate it. And I'm glad to hear that provocative is allowed. So you may hear a couple of things from me as well. As it relates to the report, I'm really happy to hear that prevention was even included, because unfortunately, as you look at substance use disorder, the emphasis has always been on treatment and recovery, which are important. However, little attention is being paid to prevention and the science behind prevention, the fact that we do evidence-based practices, that we use data for the strategies that we identify, and we get outcomes. Folks always say, how do you know that something didn't happen if it didn't happen? My point exactly. It didn't happen. And you can link it to effective prevention strategies. SUD is one of the few public health issues that prevention is not a major focus, as it is with heart disease, diabetes, when all the messages you hear are primarily around how you prevent those things from occurring, as opposed to waiting for more expensive treatment methods. When we look at COVID-19, I had to fight. I really have to say I had to fight to make sure that the CSBs, and Tamara, thank you for explaining the CSBs, to keep their prevention staff in place, because the prevention staff are known to be a part of the community, doing their work in the community, not just in the schools as traditionally thought, but being a part of the fabric of the community, whether it's with businesses, whether it's with the faith community, whether it's with real estate agents, etc. Preventionists are a part of the community. When COVID hit, one of the messages that I had to send strongly is that it's a crucial time for prevention staff to be in place due to the heightened risk of suicide, substance misuse, depression, and anxiety, all brought on by that social isolation, not having those supports really close. And in the report, it mentions how important it is for heightening awareness and education, which is true. Preventionists during COVID-19 were very nimble in their ability to do that. They did it virtually, primarily, even though some things still occur in person. When it comes to some of the virtual opportunities that they provided the community, many of them went to Facebook, had Facebook Lives talking about coping mechanisms, positive coping mechanisms, as opposed to misuse of substances. They were working really closely with parents through Facebook Live, because we all know that parents had to become not just full-time workers at home, but they also had to become teachers as well. So a lot of juggling, a lot of increased stress, a lot of anxiety, and just not having the skills needed in order to cope without relying primarily on substances. Another piece is the fact that community coalitions really went into action to continue to meet, to continue to discuss what was going on in the communities. We were hearing about the increased numbers of overdoses, and therefore, as a result of that, many of our naloxone trainings were taking place in front of the libraries. Even though the libraries were closed, folks started to create appointments, individual appointments, so folks would be able to have access to naloxone. Additionally, preventionists started to send out disposal packets to the community members so that those drugs will not be diverted in such close quarters. So when they were needed to dispose of them, they mailed out disposal packets so that folks could properly dispose of unused opioids or any other prescription drugs. The telecommunications and the virtual methods that were employed as it relates to some of the prevention programs were absolutely amazing. There's a prevention program called Strengthening Families that targets high-risk families who may be experiencing food insecurity, other areas of stress. Strengthening Families went virtual, where the participation rate was 100%. When the program was in person, they had difficulty because folks had a difficult time with transportation, etc. When it went virtual, everyone had access to coming to the program. A part of the program is to provide a meal so that the family can have a meal together. So the prevention specialist decided to have DoorDash deliver the food to the family during the session so that they could protect the integrity of the program, because they wanted to get the outcomes that are you're promised to get if you practice it with fidelity. So those creative methods occurred also. one of the things that we're talking about in the future is the fact that we know, or one of our philosophies at DBACS is that we oftentimes hear how tobacco is a gateway drug, alcohol is a gateway drug. One of our new philosophies is the fact that trauma is a gateway drug. So we are looking very closely at adverse childhood experiences. We know that a lot of those things are occurring now during COVID. So we're going to have to be ready to help build self-healing communities as it relates to addressing adverse childhood experiences. We know that domestic violence has gone up. We know that, once again, overdoses have gone up. So there are parents and caregivers in those households that have created a heightened level of risk for the young people and children in those families, so that we know that our ACE efforts have to increase. So I dare say one of the things with prevention, we go well beyond just heightened awareness and education. We also look at policy. One of the biggest outcomes of two of the community coalitions in our state, one of the outcomes, because there's many as it relates to policy, but one of them that I always tout is the fact that they realized that veterinarians were not a part of the prescription drug monitoring programs. They had done focus groups in their communities to find out that folks were taking pet dogs from the pounds, injuring the dogs, and then taking them to a vet to get prescribed an opioid. As a result of collecting this data, and once again, I want to say, prevention uses data to identify strategies for their local communities. They took this data to their legislator. Fast forward, that legislator provided a bill to the General Assembly. That bill was passed, and so as a result, veterinarians are a part of PDMP. So therefore, I always emphasize it's really important to make sure that prevention gets adequate resources, because Virginia is one of the 4 states in the country that provides 0 resources for substance use disorder prevention, at the same time that there's $42 million provided for treatment and recovery services. And prevention services in Virginia are supported primarily by federal block grant dollars, unless you're in a community like Fairfax County, where local dollars help to support substance use disorder prevention services. So kudos for the report for including prevention. Sometimes I like to see it in bold print, but thank you for having it as a part of the report. Back to you, Laura.
Thank you, Gail. I appreciate your passion around the topic as well, because I know you've struggled with this and are really trying to develop new approaches for prevention and are just the strongest prevention advocates. So I also want to thank you publicly for encouraging us to add prevention to the report. I think we struggled with being very treatment and recovery focused at first, because we were just so alarmed with what was happening with the substance use disorder population. And we just would have been so remiss if we had not integrated the prevention continuum into the report. It would have been an injustice.
Can I just make a final comment, just a quick comment? Those same executive directors that wanted to furlough their prevention staff in a meeting on last Friday, and all of the VA-CSB, all of the CSB executive directors have said they do not know what they would have done without the prevention staff in their collective 40 CSBs. So that was huge. So just wanted to say that was a positive outcome.
Absolutely, absolutely. And I think it's conversations like this that increase the awareness around that full continuum of prevention, you know, and all of the benefit that can come from the various levels and strategies related to that. I don't know about all of you, but I am just sitting here still synthesizing a lot of the comments that were coming through from our panelists. I want to thank our panelists very much for joining us today and for sharing your insights and helping us think a little more worldly and in a rounded perspective so that we can advance this moving forward. Just a few concluding remarks. The report was designed to help organize our thinking around this and to advance systems preparation moving forward. And you might be asking, well, what can I do with this? We've had some examples that have come out from our panelists about what they might do with it and encouraging the advocacy piece of this. But I would like to empower you all to also think through how you can be a part of taking action related to development of that infrastructure moving forward. In all of your roles, there is an opportunity to continue this conversation with critical decision makers in your organizations and really start thinking through what can we do to be more prepared in the future, but also, and the question is, what can we do right now to go ahead and get prepared for the future, but also what can we do right now in our current circumstance to put some shims in place and try to manage some of the reaction that has come from just trying to deal with substance use and recovery in the present moment. So thinking through that, I've heard many ways today from our panelists how this report can be used as reinforcement and validation for what they were trying to do and are doing in their organizations. I also have heard that it can provide some greater focus and maybe a direction for some people moving forward. Again, it is designed to be complementary, but I think our panelists have helped highlight where some of the benefit from additional funding really could be had as it relates to telehealth, as it relates to access to MAT, and thinking through some of those issues. I also want to highlight something that Gail said, that the prevention of substance use at all levels is critical to reduce the prevalence of use. And so really hitting it very much upstream and preventing that use, and if not preventing it, identifying risky levels and helping to mitigate some of the more severe use through greater attention to harm reduction strategies, as Dr. Sharfstein drew out. So I encourage you to carry forward these recommendations. I'm still simmering over these implications for policy that were suggested, and I was really intrigued by this idea of different models of overdose response and thinking through some of that and how we can empower the treatment system a little more to really own this space in some way. So I just want to conclude with encouragement to continue to advocate, to carry these thoughts forward, to work towards developing in every way possible in your sphere those critical infrastructures with strategies that can be implemented rapidly, and that requires the preparedness right now and starting those discussions. So be a part of this, carry this forward. I know we've got maybe 1 or 2 minutes left on the webinar, so we have around 41 participants or so, and I think it's okay to open it up for questions for our panelists. So Eric, what do they need to do if they have a question?
Sure, if they have a question, they can hit *6 to unmute themselves. If they're using the computer app, they can just click the unmute button. Looks like maybe Hugh has a, well, maybe not. Yep.
Okay.
They can also put in the chat window if they have a question they don't want to verbally say anything.
Okay, I know a lot of content was covered, and I just want to advance the slide here. At the bottom of this slide, you will see a link to access the report. Eric, is there any way you can also paste that link in the chat box? It will drive.
Yes.
Thank you. It will drive you straight to the report where you can download that in PDF form. Also here you'll see the email addresses of our panelists, our co-chairs for the task force, and myself. So please reach out if you have any questions or further comments. We really would love to hear from you on how you think you can best utilize this report and any other thoughts that maybe the discussion provoked for you. Thank you all for joining us today. Thank you, Dean Hartley and Tom, for hosting this, Washington Baltimore HIDTA for hosting it. Thank you to our panelists, and thank you to our co-chairs for helping coordinate the task force. Obviously, a big thank you to all of our task force members who came together, and also a special thank you to our external review committee. It was really the work of both teams that did produce the balanced nature of this report. Thank you all.